Transforming care through genomic medicine, personalized therapeutics, health services and outcomes research, and innovations in healthcare delivery. We're Children's Mercy Kansas City, presenting our audio interview series, Transformational Pediatrics, with host Dr. Michael Smith.
So our topic today is EOS and 3D modeling. My guest is Dr. Nigel Price. Dr. Price is the Associate Professor of Orthopedic Surgery at the University of Missouri, Kansas City School of Medicine. Dr. Price, welcome to the show.
Well, thank you for having me. Good morning.
Well, let's start off with what is EOS and how common of a condition is this?
Well, EOS can apply to two different phenomena. The EOS is early onset scoliosis, but that's just a subset of kids with curves. And when we think of EOS as a technology and as a way of imaging, that's a fairly new technology that allows lower dosing of radiation. And when we have the add-on, the Stereos software, we can actually render a 3D image, a three-dimensional image of the spine, and that's a tool that we are currently using for planning our surgeries and planning our care.
Yeah, so let's go a little bit more into the EOS imaging technology. How new is this? What are some of the benefits of it? And then I'd like to also just get into, how has this changed pediatric orthopedic management? So let's just start with a little bit more about that technology.
So the technology has been in play for over a decade and developed by a French physicist who I believe actually was a Nobel laureate as a result of this technology. But essentially it allowed imaging in a way that we didn't have to chop up the patient and stitch the images together. So the resolution was better and also less distortion. A very happy consequence of this technology was that the amount of radiation that the patient received was less. And so we've acquired this imaging at our institution about a year and a half ago. It looks a little different from a conventional radiology suite in that the patient steps or is positioned in a sitting position in a device that looks a lot like a big, tall orange closet with an opening. And the tech sits in there, positions in there, and then is able to capture both the front view and a side view simultaneously. So many centers in North America have acquired this over the last 5 years, and my understanding is that many are seeing the advantage of a lower radiation technology, particularly in patients who require frequent imaging, as spine patients do.
Yeah, so you mentioned better resolution, right?
Yeah.
And then lower radiation. I mean, those are huge wins, right, across the board.
Well, they are, especially I'm a pediatric orthopedic surgeon, and our commitment to our patients and our families is to image gently, which is a phrase that's often used when children come into play, that we want to reduce the amount of radiation that they acquire because it can have long-term effects in terms of potential for cancer. So that's our commitment to our patients. So this technology has allowed us to image the entire spine and the lower extremities in a way that reduces the radiation. And we just acquired another add-on recently, which is a special filter, which reduces the amount of radiation by almost the power of 10. So instead of 1/7 of the typical, now we're something like 1/30th to 1/50th. So it's really a nice boon to the patient care.
Yeah. So Dr. Price, tell us a little bit more, though. So what's the result of this? At the end of the day, we're imaging better, it's safer, you're getting a better image. What does it really mean to you as a surgeon?
Well, to me as a surgeon, it means that I can preoperatively plan my cases and with a nice high resolution X-ray, I can assess my patient's spine. My day job is spine surgery, so I can see the structures very well. And with the additional software, the Stereos component, I can actually assess that spine in 3 dimensions. I can, with the help of a technician who digitizes the X-rays, we can look at that spine in multiple planes. We can determine where the most of the deformity is, and we can plan both bracing technologies, a non-operative approach to care, but we can also plan our surgeries in that we can, with a 3D image, we can concentrate our technique to maximally correct that spinal deformity. So it carries into the operating room with us.
Yeah. Is the imaging technology also helping in, knowing which patients are going to benefit most from surgery, some that can do some of the bracing technology? I mean, is it helping you also to make those kind of decisions?
When you have a technology that has a little less radiation exposure, in this case, quite substantially less, we do feel that we can sort of optimize the interval that they come back. I mean, I think because we're sensitive about radiation exposure, we sometimes would have them maybe come back less frequently, and I think when we do the summation, when we do the math on exposure, we can kind of tailor the care, in terms of how frequently they come back, and particularly in patients who are rapidly growing and their curve is growing with them, we can optimize their scrutiny and their vigilance, and we feel a little less perhaps guilty is the word in terms of the number of radiographs they're getting. It's not that we're being cavalier about the number of films at this point, but we can sort of optimize the intervals that they're seeing, and so that way we can keep tweaking their bracing, for instance, or time their surgery a little bit better.
What does the future look like for this type of imaging technology and 3D modeling?
Well, actually, some investigators in Quebec, Dr. Perrot and his group and others have collaborated with this technology, and they've brought us into a whole new era of assessing the spine and stratifying risk. So, in other words, based on the 3D modeling and the classification, we can now eventually, hopefully, determine the risk of progression. So that if we have a sense as to how likely it is for that patient's curve to get worse, we can then tailor their treatment, tailor their follow-up. So some children, for instance, historically would have just kept coming back every 4 to 6 months for X-rays. Well, now if we stratify their risk as low, they don't have to come back as frequently for radiographs. Whereas in another group who have a high risk of progression, we can perhaps see them more frequently and not have a greater risk of missing their curve progression. Since we don't really have a great handle on why most of the idiopathic patients are getting their curves, we don't really have an intervention, medical intervention. So we have to consider bracing and/or surgery. So we can hopefully keep a lot of those kids out of the operating room if we can.
Right.
We can successfully non-operatively treat them.
Dr. Price, thank you for the work that you're doing, and thanks for coming on the show. You're listening to Transformational Pediatrics with Children's Mercy, Kansas City. For more information, you can go to childrensmercy.org. That's childrensmercy.org. I'm Dr. Michael Smith. Thanks for listening.